Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from Italy, Prof. Rocco Scalabro. He is an adjunctive professor in the physical medicine, rehabilitation, and social physiology at the University of Messina, Italy, and a visiting professor at the Neuro Rehabilitation at the Linux University. In the last 10 years, as the head of Innovation Technology in Neuro Rehab Lab, he has demonstrated growing interest in innovation technology with regard to robotic-assisted gait training, virtual reality, and tele-rehabilitation, rehabilitation-induced functional connectivity, and translation neurorehabilitation. We are extremely honored to have him today at our webinars, and today he'll be talking about robotics in neurorehabilitation. The speaker for the second session of today is our honorable guest from China, Professor Liu Yang. Dr. Yang is an attending neurosurgeon at the Department of Neurosurgery at the Beijing Tsinghua Chang'an Hospital, Tsinghua University, China. His clinical interests are dedicated to translational research on functional modulation and reconstruction of brain and spinal cord. He has independently completed nearly 40 spinal cord stimulation surgeries, including the spinal cord stimulation implantation surgery of multiple spinal cord injury patients. And he has reported for the first time remote programming application of spinal cord stimulation internationally, introducing China's pain management experience during the COVID-19 pandemic. He was selected as a Beijing Science and Technology Rising Star in 2021 and the Young Elite Scientist Sponsorship Program in 2023. As a core member, participated in the epidural electrical stimulation for paraplegia following spinal cord injury study and is responsible for the design and clinical practice of the clinical trial. He performed the first and second surgeries in China and also was a major participant in the post-operative programming stage. We are extremely honored to have him today at our webinars, and today he'll be talking about neuromodulation in spinal cord injury, epidural spinal cord stimulation. The chair for the first session of today is distinguished faculty from India, Dr. Sharan Srinivasan. Dr. Srinivasan is the head of neurosciences at the Bhagwan Mahavir Jain Hospital, Bengaluru, India, and is also the CMD of the PRS Neuroscience and Mechatronics Research Institute. His clinical and research interests are focused upon neuromodulation and neurorehabilitation, and he has won several awards for his contributions towards restorative neurosciences. We are extremely grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is our honorable guest from Germany, Professor Georgios Mattis. Dr. Mattis is senior consultant for neurosurgery and he leads the chronic pain spasticity sector of the Department of Stereotactic and Functional Neurosurgery at the University of Hospital of Cologne. He is a member of the German Neuromodulation Society and International Modulation Society, and he serves as a reviewer for many international journals and is on the editorial board for neuromodulation technology and neural interface and interventional pain medicine and neuromodulation. He has been involved in many clinical studies and has been active as an instructor for many colleagues in Germany and abroad. We are extremely grateful to him for accepting our invitation to chair the session of Professor Liu Yang. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers, chairs, and their wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Libun Singh from Malaysia is my co-host for today. With that introduction, I would like to hand over this online podium to our first chair, Professor Sharan Srinivasan.
Good morning, good afternoon, good evening to all of you from Bengaluru, India. And lovely introduction of Professor Rocco Scalabro. I think I'm really keen to listen to you speak about how the robotics and what you have been up to, because I think it's a very similar interest. So definitely would love to hear from you. So over to you, Professor Rocco Scalabro, to give your talk.
Okay. Thank you for inviting me to this interesting meeting. In this presentation, I will show you how we work in Sicily with the use of robotic rehabilitation, doing some research, from research to clinical practice, and try to give some advice for the use of the different devices that we have in rehabilitation. But before talking about rehabilitation, we have to understand, we all know that after we have a brain injury, or spinal cord injury, there is the ability of our central nervous system to respond to intrinsic and extrinsic stimuli by reorganizing the structure, the function, and the connection. And we can divide these neuroplasticity changes into two main stages. The first stage is the recovery stage that occurs mostly spontaneously and evolves over several weeks And in this phase, we have to help the neurons surrounding the area of the cell death to reactivate by modifying inflammation, lifting the ascites, or reducing the late neural death. We can use growth factor monoclonal antibodies, but as rehabilitation specialists, we use activity-based therapies, and among them, robotics play a pivotal role. The same thing is in the chronic state that usually occurs 3 months post-stroke, for example, and up to 6 months when we have to deal with language or cognitive function. And in this phase, we have to improve the reorganization of the brain or the spinal cord areas by increasing the synapses and unmasking latent neural networks. And also in this case, robotics is very useful to work. If we want to boost the recovery, we have to start as early as possible. We have to provide visual or acoustic or different feedback. We have to do many repetition, high effort. We have to train functionally, train beyond the patient present capabilities. And the most important thing, we have to ensure an active participation and motivation of the patient. So if you want to have an effective rehabilitation, we can synthesize that we have to work as early as possible. The rehabilitation should be intensive, repetitive, active, and also task-oriented. And we know that robotics can help and can do all these things because it is able to reduce the required effort and time. It can improve the reproducibility of the kinematics in specific movements, I mean gait or upper limb movement, by increasing the intensity and the volume of motor exercise. And this is a better way to improve motor and cognitive outcomes. But all the electromedical device to be defined as robot should be, or at least should follow the 3 laws of neurorobotics that has been stated by Asimov. The robot may not injure a patient, must obey to the order given by the therapist, unless it does not harm the patient itself, and must adapt the behavior to the patient ability. And to do this robotic should have, as you can see here, a control system. And if we focused at this time on gait robotic rehabilitation, robots may be classified into stationary system, overground, and wearable robotic systems. The stationary systems are made up of a fixed structure, a mobile ground that could be a treadmill or foot place, and they are divided into exoskeleton device and effector devices. We can see the main difference in the next slides. But then we have the overground working system and also the wearable device, as I told you before. But if we try to classify and divide the robotic device that we use commonly in clinical practice or also as research, we can define the robots feature by dividing them into exoskeleton and then the effector. The exoskeleton, as you can see here, present with joint control, but with high interference and friction to the joint, of course. They are less accommodating to individual gait variations. So they have a standard, for example, gait pattern, but can be used in patients that are most severely affected. For example, we can also use in paraplegia. The end effector, as you can see here, present with no joint control. They have low interference, but they are not able to generate the stance phase of the normal gait pattern, but they should be used in patients with mild to moderate impairment. It means that patients should be able to stand alone if they want to use this kind of devices. And I want to show you this interesting picture where we can bridge the gap towards overground gait training. As you can see here, if we want to help the patient to relearn the gait movement, we can start with verticalization as early as possible. We can train functionally and increase intensity. We can increase also the functional challenge and then use the assistive device to transfer into real life. And if you want to start just to follow all the device, the main device, you can see that one of them that can be used as an early and safe device for mobilization, we can use the Arrigo device that you can see here. The device can combine the gradual verticalization with such robotic movement therapy, so to stabilize the patient in the upright position by also improving the cardiovascular system and also increase the tolerance to the orthostatic hypotension. For example, we can further improve this kind of problem, hypotension, by using also the functional electric stimulation that can be applied during the gradual verticalization, just to further improve the circulatory system. And the patient can be trained in an intensive and safe way in an early stage of the disease, also in the acute care unit. And we have also experience with this patient in patients that are more severely affected by those affected by disorder of consciousness. But one of the most known and most famous device that has been used all over the world is the Logomat. The Logomat, you can see here, is a robotic device that consists of a powered gate orthosis with integrated computer-controlled actuators at each hip joint, a body weight support, and related to this treadmill. The main version of the device, main type, Nanos and Pro, share tailored orthosis, customized training parameters like the body weight support, speed, range of motion, and guidance force. They have a visual feedback, and also they can store and monitor the patient improvement. But only the advanced Pro devices present with an assessment tool, especially for LROM and force, a research module. But what makes the difference, we will see also in a paper published by us, is the virtual reality or the augmented feedback. By the way, after the Pro, we have a new module, it's the 3D module, that is characterized by a challenge package which is able to speed up the Logomat with the patient performance, and then also such 3D module. You can see here, this is a normal gait pattern of the patient. If we, with this module, have the possibility to perform a lateral translation up to 4 centimeters, transverse rotation up to 4 degrees, this gait pattern resembles the normal gait pattern of the patient. And I want to show the first video that was done some years ago in one of our gym. You can see here, this is the Logomat Nanos, that is called like this because it does not have virtual reality. You can see she is a patient affected by traumatic brain injury. Then we move to the other one, the Pro device. The patient, if I remember, it was a Parkinson's disease, is doing his rehabilitation by following this interesting scenario, and this is to improve the motivation and also participation to the rehabilitation. And the third one that you can see here is the 3D module. Sometimes our physiotherapists, but it's not so necessary, it can help the patient to improve their functional challenge. This is a dynamic body weight support, and this is the 3D module that helps the pelvis to move more freely and having that kind of gait that I showed you before. So, what literature tell about the use of this specific device in different neurological disorders? Commonly speaking, we can find that literature says that Logomat can be effective in patients with spinal cord injury, stroke, Parkinson's disease, and also cerebral palsy. But if we treat patients with moderate disability affected by SM, the Logomat is as equal as conventional physiotherapy. So you can see in the next slides, when we choose to use robotics, we should find the exact patient, especially the exact time when we have to use it. And briefly, in this paper, we have compared the use of the Logomat Nanos without virtual reality to the Logomat Pro with virtual reality in patients affected by moderate to severe multiple sclerosis. And we found that after the treatment, both the patient had good outcomes, but patient performing virtual reality outperformed. They get better result, especially in the Berg balance and scoping strategy. And the idea that the virtual reality made a difference was then proven in patients with stroke in this neurophysiological pilot study where we found a better improvement of neuroplasticity concerning those neurons belonging to the mirror neuron system. Concerning the end effector, you can see here also in our facility, we have the geosystem. The geosystem give a different model of gait pattern and can help also to help the patient to ascend and descend the stairs. I want to show you our rehabilitation. This is the same gym that I showed before. As you can see here, the difference is that biomechanically the knee is free, so the therapist can help the patient to move. And as I told you before, the most interesting thing of this device is the possibility to train the patient to ascend and descend the stairs. And this is a very interesting device that patients are very happy to work with it. After, for example, they do they exercise with the Logomat. And concerning the literature of end effector, including the geosystem, we have less randomized clinical trial. And as for the current literature, end effector seems to be more effective in patients affected by stroke and Parkinson's disease. Another kind of device are the overground devices that can be used as a medical device for military purpose and also industrial purpose, which is the main feature. They can help the patient to practice gait, postural and balance exercise in a safe, controlled manner and allow them to move under their own control rather than to predetermined movement pattern like the Logomat and geosystem do. And this is one of the most used is the rework that provides powered hip and knee motion to enable individuals with spinal cord injury to stand upright, walk, turn, but also climbing and ascend stairs. And it can be used both as rehabilitation assistive device. It works thanks to this sensor that is applied in the upper part of the body and control the patient through the small changes in the center of gravity. Another interesting device that we use in our center is the ExoGT because it is able to treat patients that present with a lesion up to C5 complete level, any level of incomplete, and it is also good for hemiparetic patients. And it works in a different way because the sensors that are present in these plates can detect the weight shift laterally in the prostep and laterally forward in the prostep plus. And it has two important software, the variable assist that can help the patient and adapt to the patient need, and the smart assist that can help the patient to do pre-gait, squat, balance, step in place, or free gait. And this is indeed the Indego. The Indego can be mostly be used in patients with spinal cord injury, and thanks to the fact that it's really easy to wear and a light device, its weight is about 30 kilos. You can see here that is really easy to join. It can be easily used and also used as a better assistive device. Here, the patient is working with 3 therapies because this video is related to the first training of my QPT. And this is the trainer that she is trying to teach them how to use properly the device, but the patient can move it by themselves. And All the exoskeleton, especially the powered exoskeleton, can be used in different neurological disorders, I told you before, but most of the literature is in spinal cord injury. And we saw, as per this interesting narrative review, that they can improve their functional outcome beyond the motor recovery. Indeed, patients with spinal cord injury undergoing this kind of device can improve and reduce spasticity. They can improve pain. They can also increase heart rate and oxygen consumption using the device as a cardiovascular exercise tool. Then we have also improvement in metabolism and bone health. There are conflicting results concerning the bowel function, but it seems that the powered exoskeleton may work in improving stipsis because, ambulation can improve the peristalsis of the gut. They also are used for social ambulation, even if a few of them can reach the velocity that is up to 1.2 meters per second. And of course, if you can move by yourself instead of being in a wheelchair, and then you can walk in upright position, this improves your psychological well-being and also quality of life. And to this aim, we have published this paper showing how the use of innovative technology in patients with spinal cord injury can improve not only motor but also cognitive function. And we did it by a specific rehabilitation pathway where patients affected by spinal cord injury, they had an objective assessment, a deep gait analysis, a specific rehabilitation plan, a multidisciplinary approach, including robotics, virtual reality, and home automation. And they were also followed to the hospital or also telerehabilitation, and this pathway worked to improve their functional outcome. Concerning stroke, we tried with this Italian consensus conference that I lead concerning the stroke guidelines, trying to understand if robotics could have a place in the use of clinical practice. And we found that by analyzing the main guidelines, especially the American guidelines, that the earlier the trainer starts, the better, of course, is the gait recovery. But robotics seems to work in stroke patients when patients are more affected, and especially within the first 3 months. And it is a good tool in add-on for the improvement of different functional recovery. It seems that RACT works better when it is coupled to FIS or VR. But the problem is that we are working on it, that we really don't know when we have to start, how we have to do the training, for how long, how much we work, and how number of sessions are necessary to improve, especially in patients with chronic stroke. And with this consensus on those multiple sclerosis, we gave some advice concerning robotic rehabilitation. And we found that, for example, we can use the robotics according to the patient ability as per the ADSS. Indeed, if patients are most severely affected, we have to use the exoskeleton, and the factors are good for moderate, severe to moderate patient, powered exoskeleton for moderate patient, as well as body weight support treadmill training. Soft robotics can be used in moderate patient, but in patient with moderate to mild gait problems, also conventional physiotherapy can be used. For example, if they have an ADSS of from 0 to 2, they can also use only conventional physiotherapy instead of robotics. And that was related to the lower limb. Concerning the upper limb, the classification is the same. We divide the main robotics device into exoskeleton and the factor. Among the exoskeleton, the Aramis, that is an Italian product, and the Armeo Power are the most known, as well as the Ryogo and the Mitmanus as the end effector. And the biomechanical principles are the same as for gait recovery. And also in this sense, in this publication with my friend Fisiacic Morone, we try to use the robotics according to the arm impairment as for the Fugmeyer upper extremity scale. And you can see here that it is the same. If the patient is severely affected, you use the exoskeleton, moderate affected and effector and or sensor-based training. But if they are mild affected, you don't need to use robotic. This is what I want to tell to you. Robotics works, and it works better if you can couple it with conventional physiotherapy. But you have to understand which is the precise time when you have to use it, especially when the patient are severely affected. And it's the same thing for the upper limb. And this is what this Cochrane review that has been published some years ago demonstrate for the use of electromedical device in rehabilitation. It seems that in stroke, it works on improving arm function, arm strength, and also activity of daily living. And significant improvements are found, unfortunately, also in acute and subacute phase, but this seems not to be proven in the chronic phase, maybe because of the intensity of the treatment. But the result indeed should be interpreted with caution because, of course, trials are different in intensity, duration, amount of training, type of treatment, and also the participant characteristics. And I want to briefly show also some specific device that we have in our center. This is the most known Armeo Bauer. You can use it in patients with severe upper limb lesion. You can see here that you can treat the shoulder, the elbow, and also the wrist. And the improvement is mainly related also to the possibility of this augmented performance feedback that helps the patient to stay concentrated with more motivation. The Armeo spring can be used also in patients that should have, by the way, some remaining motor function. It has more or less the same feature, but it's not the real specific robotic, but it can be just considered an anti-gravitary device. Then you have to use your own motor function to make the device be used. In the last years, we have paid more attention also to the use to the hand function. You can see here that we use this robotic device, the Symphonia, the Gloria Symphonia, that can be used for bimanual mirror training. It means that the movement of the healthy hand are recognized by the devices and that reproduce it on the contralateral way. So it at the same time is a motor training, but also activate the mirror neuron system through the action observation. They can be used in a passive way and also in an active assisted way. An interesting but less used device is such kind of end-of-op. It is an exoskeleton that is worn on the dorsal side of the hand. We have these surface electromyographic signals that detect the patient will, and then the patient is just able to start the movement that is then completed and analyzed by these signals, and they are transformed into the desired movement. And another interesting device is the maybe one of the most used for finger hand therapy is the Amadeo. It simulates the natural grasping motion and executes such kind of automatic movement sequence, as you can see here. It is really and easily adjustable for children and adults. It has got an evaluation and follow-up of the patient. It can be used also this in the passive and assistive therapy, and it provides also the patient with a real-time feedback. And one of the most interesting paper that we did on the upper limb was done also with such kind of device in patients with chronic stroke. We compared 25 chronic stroke undergoing the Amadeo training with those undergoing a simple occupational therapy. They had the same amount of intensive training, even if the patient were on the same chronic stage. And we found that although both group showed improvement, the group undergoing robotic rehabilitation presented with better functional outcome, especially for the Fugmeyer and 9-hole peg test. And it was paralleled by a better reshaping of the movement-related brain oscillation and connectivity that was analyzed by the use of the EEG. In simple words, we found that robotic determined a better improvement of the maladaptive plasticity that we have after a stroke, also in the chronic phase. And also in this case, we thought that besides the specific repetitive intensive movement, the virtual reality led an important role thanks to the motivation enjoyment, to the fact that in such virtual environment, we have the knowledge of results, the knowledge of performance, and this is a better way to reinforce, to improve the reinforcement learning and then neuroplasticity and motor outcomes. And also here, I want to show you how we work. We are trying in this gym that is dedicated to the upper limb to work on the different district of the upper limb. And you can see here that is a patient affected by stroke working on the Amadeo. This is the Diego device. It's an anti-gravity robotic treatment that also uses virtual reality, and it can be used in a monotherapy or also as bimanual therapy. The patient also is affected by stroke and is doing, with the help of the therapy, some exercise to improve the upper limb extremity. The gamification is fundamental to help the patient to stay motivated and concentrated into the rehabilitation field. This is another devices. The motoric device mainly work on the elbow and somehow also the shoulder and the wrist, but the elbow is the main focus of such kind of robotics rehabilitation. This is a linear actuator, and the actuator is robotized, as you can see here. And then we also use some sensory-based training. This is not a robotic device. We have just sensors that are projected to the gamification. Of course, to use it, patients should be less affected to improve their upper limb function. What we can say in general about the advantages of robotics over conventional physiotherapy? If we use a robot, robots are they can provide us with a better quantifiable and objective assessment. They are highly motivating thanks to the gamification, as I show you, that they are able to give and provide the patient with a more detailed and timed sensory feedback. The feedback given by the therapist is subjective. Sometimes therapists are not so involved, and so patient can't have their feedback back. And important things that robotics can give a more intensive and repetitive training, and you know that for such movement, especially for the gait training, intensity and repetition matter. Of course, it has got some limits and some disadvantage. For example, short-term, they are more costly than the physiotherapy itself. They can be space-consuming. Not all the facility have big gym to put this device. There is a risk of obsolescence. And then the devices, as I show you in the last gym, are specific for individual limbs. So you should have, for example, different device to treat the different part of the body, and the therapist indeed can do it by itself. The problem with the robotics is the limited communication and interaction, even if, as you know, the artificial intelligence is going to fill such kind of gap. So in conclusion, as future direction, we are working on trying to improve and boost further neuroplasticity by combining the different approaches, robotics with muscle vibration, robotics with drugs, but especially with the non-invasive neuromodulation. You know that if you use transcranial direct current stimulation or transcranial magnetic stimulation before as priming or after to consolidate neuroplasticity, you can have better results. And of course, the use of artificial intelligence will help us to provide a more tailored rehabilitation plan with different patients with neurological disorders. And thank you for your attention.
Thank you, Professor, for a very good explanation of what's going on. So do we have any questions, or I can ask a question? So you said that there's still, unclear about when to use the devices, how long to use the device. Is there any work happening, to actually put some protocol in place to get started? Because you understand, in resource-constrained countries like ours, if you have, and many of our patients, or most of our patients, pay out of pocket. It's not insurance-driven. So we have to say something to the patients to justify this whole thing.
At this moment, as I told you before, we have really problem of this, and thanks for the different of high income or low income, because one of the problem is who should pay for robotic rehabilitation. We don't have really problem because we have problem of length, for example, of state. I mean, we are involved in a protocol and international protocol with USA or other Western Europe country. But for example, in our country, in Italy, is the government that pay for rehabilitation. And if patient has the luck to be in our facility, research facility, they can stay, for example, 2 months, or if is a severe acquired brain injury, also 6 months. So, for example, we can treat the patient for 20, 30, 40, 45 training with the robotics. And you know that in USA is not possible because the insurance pay, the length stay in America is really lower than in Italy. So the protocol can be the same because the problem is, as you perfectly told before, also related to the insurance or not. If they don't pay, we don't know. No, we don't know. If they don't pay, the patient can't benefit as much as can do when, for example, government can pay for them. And at the moment, unfortunately, we don't have protocols because we know that we should use robotics within the first 3 months, especially in stroke patient. The other problem is, and I can ask also the other, we should use in neurodegenerative disease. It works or not? We don't know, but insurance won't pay for Parkinson's disease to have robotics, of course. They can pay for stroke, they can pay for traumatic brain injury, but they don't pay for chronic patient, they don't pay, and so we don't know how to do the protocols. My research center is doing protocols on every kind of neurological disorders, as you can see by my publication. But it's just a lucky reality. It's not the real world. And we are trying to translate into the real world practice. It's not so easy because it's different from our reality.
Got it. Second question is about HAL. You showed the HAL robo of Japanese, a Cyberdyne robot. Do you have any experience of using that? Because they say they're slightly different from the other lower limb exoskeletons.
No, because my experience are with those that I mostly talk about, with the Indego and the Exo GT, because in our facility we have that. I just showed the HAL, but I don't have, just to say it's an exoskeleton, but I don't have any kind of experience, unfortunately.
Any other questions?
Yes, of course, we can invite the president-elect of WFNS, Prof. Luis Borba, who is here with us.
Borba, welcome.
Welcome, Prof. Borba.
Hello, good morning.
Good
I'm
morning.
learning a lot here. See, learning. More we study, more you see, more you know. You know that you don't know about the work of the brain. See,
Yeah.
in the plasticity, you make a big difference.
Agreed.
This kind of rehabilitation is more educate the brain. See, to have a new functions. It's wonderful to see there. The cost today may be high, but for the government, the cost to keep this kind of patient during the entire life may be higher than the cost to invest in this kind of facilities. I really learn a lot, and thank you very much. I need your contact to contact you later. Maybe you can do some together and send this to the whole world, this education. Thank you very much, sir. Thank you very, very much.
Of course, I'm really happy, and I'm really prone to have a different collaboration, especially with the different specialty, because you can complete and understand better.
Thank you.
Thank you.
Over to you, Mr. Murthy.
My co-host, Dr. Liu, any questions from you?
Thanks, Raja. Thanks, Prof, for a very nice presentation. I have three short questions, Professor. First, regarding afferent feedback, I always think that passive limb movement are important to provide those feedback. Do you think? Can you tell us what is the mechanism of, if there any, because there's no muscle contraction actually in passive movement, but I always think that it's important for the recovery. The the early rehabilitation is very important. So is there any evidence to show that there's some form of afferent feedback for the neural recovery in passive limb movement? My second question, Professor, you mentioned about virtual reality. In a patient with tetraparesis, do you think there's a combination of virtual reality and passive limb movement that synchronize each other will also help in the brain plasticity? My last question, Professor, what is your opinion for the future exoskeletal in movement disorder diseases such as Parkinson, essential tremor, and other degenerative diseases? Thank you, Professor.
Okay. For the first and the second, more or less, I can give the nearly the same question. I mean that the afferent feedback, we mean with afferent feedback, especially the visual feedback. You know that especially in the early stage, when you see an action or do detection, we activate the same circuits. And this is action observation means do that movement. So if with robotics, we do the movement in a paralyzed arm, and at the same time, you can see your movement, you can further improve plasticity. And if the movement is an ecological one, what I mean with ecological, for example, instead of just do some passive movement that you can do with the therapist, you ask the patient, even if he's not able, catch the apple or catch something. For the brain is really different because the movement has another meaning if it's something that is important for your brain. That's ecological. That's why if you do something in the virtual reality that resembles something that you need to do in your real life, for example, in different scenarios, they go to the mall and they just buy something, pick up something. It's something that they do with the robot device for the end, or moving, for example, in a park. But why doing it and seeing it, we demonstrated with the neurophysiological approach that the mirror neural system is more activated, and this has good result not only at the mirror neural system level, but also on the motor level. Because you know that there is really an influence from the body schema, that is the frontoparietal cortex, to the premotor areas, because the movement is the result of anticipatory movement, that is sensory motor areas or premotor areas, and to motor areas, and they are really connected to the body schema. And we work showing the movement on the body schema, temporoparietal cortex, that has a good influence to the plasticity of the motor, and so they can work together. I mean, you move passively, but at the same time, you see that movement, the reinforcement learning, and the plasticity is really better. For the use of the device in neurodegenerative disease, I show you, if you remember, that we usually start with verticalization because the patient is paralyzed, and then we stop with assistive device or sensory-based training. It means that the patient is more able when improved to move, so it doesn't need so assistance. Neurodegeneration is perfectly the contrary. I mean, in the early stage of Parkinson's disease, we just use treadmill with virtual reality, but the patient is able to work by himself. The virtual reality helps to have a better, like music therapy, a better training for patients, for example, with Parkinson's disease. But when they became worse, we can use exoskeleton. We don't use exoskeleton, of course, at the beginning. It doesn't make sense. It's the opposite training of patient with stroke. Stroke patient do worse at the beginning and then perform better. Parkinson's disease do better at the beginning and then perform worse. So you have to imagine. I also published something like this, that is vice versa. We say in Latin, I think also in Anglo-Saxon, is that way and vice versa.
Thank you. Thank you very much, Professor.
You're welcome.
Thank you very much. I think, yes, Dr. Luya, would you like to ask something?
Okay. Thank you very much for your presentation, Professor. I was wondering that I saw some robotics appeared with functional electrical stimulation device, and in what circumstances that you want patient to use the robotics at same time with a functional stimulation? Thank you.
Yeah, we at the moment we use functional stimulation. You want to know in clinical practice what I do in research. In research, you can use it also in the other devices. I mean, also with exoskeleton. For my personal clinical practice, I use only for the erigo. I mean, we work on the gastrocnemius, especially just to help the pump and the cardiocirculatory load to improve. Also to improve the muscle and prepare the tibialis anterior for the gait training. It is a pre-gait training before the gait training itself. We just potentiate the muscle, and the difference, I think you know better than me because I saw that is your specialty, that when you use stimulation just of the muscle, you have stimulation contraction. When we use functional stimulation, the stimulation is only when that muscle is moving. I mean that if you are going to step, and in the stepping, the tibialis anterior is activated, the stimulation helps to activate and potentiate. And this is the difference, you know, maybe you will tell better, between the functional electrical stimulation that helps improve, and it can be used in an exoskeleton to avoid the drop foot. This is what we do in rehabilitation. I don't do it because I don't have at the moment any devices coupled with this, but the erigo. So I use as pre-gait. But it's very interesting to use, for example, to help tibial anteriosis, to help the foot not to drop. And so you don't have the risk of falling in the device when the device has not the plates to stabilize the ankle.
Okay, thank you.
Thank you very much. We can go back to Prof. Sharan Srinivasan to hear his concluding remarks.
So, like Professor Borba said very clearly, the more we understand the brain function, the more we understand that we don't understand what's going on inside. Now, I think that's what is very exciting in this field. There's so much still to explore and learn. But I think we all have to get as a group to see how we can help these patients get functionally better. I think that's the most important thing, because no government can afford to keep them going like that, because these guys don't die, they go on for a long time. I think as a group, we should get in to see how we can do small things to eat, the ADL functions or mobility, which are two main things that, patients look for to get functionally independent. So the caregiver burden comes down. So that's what I see. I'm speaking from my practice, because we handle about 200 patients every day in neuro rehab. So we see a lot of different kinds of patients stay with us for 6 months, 1 year, 1.5 years, all paying out of pocket. So we have to make sure that that happens. So we are in the quest, and I hope that we get an answer to that. Over to you, Dr. Raj Krishkoti, Professor.
Thank you very much. It was indeed a very novel session, and it was an eye-opener towards a new field which we have very less exposure to. Thank you, Prof. Rocos Colabro, for this wonderful lecture, and thanks, Prof. Sharan Srinivasan, for chairing this session. I'd like to inform our viewers that we are broadcasting this on WeChat, YouTube, and Zoom. Thanks to Professor Shubin. We have around 690 people who are live on all the 3 platforms. Thank you very much. So we'll move on to the second session, which is another very interesting session about neuromodulation, spinal cord stimulation. So I will hand it over to the expert chair, Professor Georgios Mattis, to say a short introduction and invite Prof. Yang Lu for his lecture. Prof. Mattis, all yours.
Good morning, good afternoon, good evening for everybody. Thanks for having me. Just a small clarification. I was leading the pain spasticity section in Cologne till March 2025. In September, I will start working in a big private hospital in Greece, in Athens, at a year. But nevertheless, I will still serve as the secretary of the German Neuromodulation Society. So back to the topic, spinal cord injury. We all know that results in devastating not only motor but also sensory and autonomic impairments. And for decades, we have been constrained by the belief that once the spinal cord is injured, functional recovery is not possible, or at best is very, very limited. Neuromodulation as a whole, and especially spinal cord stimulation, challenges this paradigm. And it's true that spinal cord stimulation has evolved into a transformative tool, not only for treating chronic neuropathic pain, what I'm doing in my own practice, but also for restoring voluntary movement, bladder control, and cardiovascular stability in spinal cord injury patients. We stand at a point where clinical neuromodulation is actually redefining rehabilitation. And it's not about applying electrical current. It's about understanding the intrinsic plasticity of the human nervous system and translating that into meaningful clinical outcomes. It's really important, in my eyes at least, that this therapy, spinal cord stimulation, and neuromodulation as a whole, represents a convergence of neurophysiology, basic science, neuroengineering, and clinical neuroscience. And to truly advance this field, we need a close collaboration between neurologists, neurosurgeons, rehabilitation specialists, bioengineers, and many, many, many colleagues bridging bench to bedside. So having said that, it's a great honor to have with us today Dr. Yang Lu, who is an expert in this field. And without any further ado, Dr. Yang Lu, the floor is all yours. Please enlighten us. Thank you very much.
Thank you, Professor Matis. Thanks for your introduction. And today it's my honor to be invited to share with you my topic today, neuromodulation and reconstruction of the spinal cord dysfunction. And this work was done by my team and originated from National Engineering Research Center of Neuromodulation, which is led by the Professor Lu-Ming Li. And I am a neurosurgeon in this team, and I mainly focused on the enrollment of patients and also the surgery and post-surgery management of these patients. And spinal cord is a complex system, just like our brain, and for it have several qualities, such as it's a chaos system, which means it's sensitive to initial input. For example, for the patient implanted with spinal cord stimulation, and if we use a different contactor that is very near each other, and we predict that the patient may have the similar sensation evoked by the stimulation. Actually, it is not, and just a slightly change of the contactor location, we could get a tremendously change of the coverage of the sensation evoked by the stimulation, which is sensitive to the initial input. Also, the system has the quality of the emergence, and just like for the physiological transduction of the sensation, and if the patient have the physiological pain, and he can know the location exactly, and he know the intensity of the pain. But for the patient with spinal cord injury, which patient have the neuropathic pain, it's hard for the patient to describe the nature or the location of the pain, because it's a complex system, and also it can emerge with some sensation that is hard to describe, such as a patient may say he has electric shock-like pain or pricking pain, but it's hard for the others to imagine and which type of the pain is. And also the system has the self-organization quality. That means without a central or the peripheral input, it can output some the pattern like the actions. And this picture shows the spinal cat. Spinal cat means it has a thoracic transduction of the spinal cord of the cat. But if we give a peripheral stimulus of the lower limb of the cat, and you see that the cat can walk just immediately with the stimulation, and even it can change its velocity. And also there are others, some qualities that this system has. And this system, these qualities just induce that the spinal cord is a complex system and it's hard to know the every element of the system, and which is, I think, the main obstacle and to recovery from the dysfunction of the spinal cord. And there's another thing that is very interesting. It's asymmetry quality that between the extent of the spinal cord injury and the functional recovery. And just like you see the three MRI images and below, and these three images, you see the different patterns of the injury to the spinal cord. But the function of the three different patients are the similar, and they both they are all the Asia A grade patient. And also the just right above picture, you'll see two just transection pictures of the rodent spinal cord. The gray area means the injury area, and these two rodent, you see there are different extent of the injury area, but they show quite the similar the locomotor score of the rodents, and which means a symmetry quality of the spinal cord, anatomically or the functionally. And this is just because they are very complex network that within the spinal cord, and even the quite similar extent of the injury can lead to a totally different functional outcome. And to today's topic, I would like to share with you some the cases and some problems, and we have done these years. And we focused on the epidural electrical stimulation and for the patient who has a dysfunction of the spinal cord. And the patient with spinal cord, whether some etiologies, whether it is from trauma or the oncology or vascular disease or systematic disease, and mostly patient will have some the spinal cord dysfunction, such as motor dysfunction. It's very easy for us to see that the patient may on the wheelchair and the paralysis of the lower limbs, and patient may have some sensory dysfunction. They cannot feel, or they have some neuropathic pain. And also patient may have some autonomic problems, and which is hard for the others to define and to find. And also this problem is most irritating symptoms for the patient, because it's not only about the quality of life, but also it's about the dignity of these patients. And for the etiology of trauma, and annually there are about 500,000 patients who suffer from traumatic spinal cord injury every year and globally. And right now there is no effective treatment that can reverse such conditions of these patients. And our program is led by the Professor Lu Ming Li, that also the Professor Gui Hua Wang is our senior neurosurgeon, our team, and the Professor Pan Yu, and who is the rehabilitation physiologist. And this project also supported by a lot of national levels. And the first project we are mainly focused on try to reconstruct the ambulation ability of the patient who have the spinal cord injury. And for the device, we use the epidural electric stimulation. The device is our self-development and domestically manufactured. And it can have a function like the simultaneous recording and stimulation. And also the electrode can support the 32 contact, and which right now is the most condensed electrode that available that in the community. Right now we have enrolled 4 patients and who has a spinal cord injury, and all of them we have reconstructed the ambulation ability. This is the first patient. First patient is a 26 male, and he's an HB patient. He was an HB patient, and he was enrolled in 2020. This video shows that before the operation, and we try to use the body weight support, and also with the help of the therapist, help him to stand. You can see he has a totally weakness of his lower limb. And the neurological level of the spinal cord injury is thoracic 5. And also the followings are the scores of the lower and upper extremity model. And afterward, first we would like to show the outcomes, and just like after 1 month after we implanted the spinal cord stimulator, and we give orders, and with the stimulation on, and we give orders, and to use the left lower limb, and you see the patient can, to some extent, to control the some angle, the knee, the hip. And also the first two patients are both HB patient and enrolled in just complete the trial in the 2021 and the 2023. And before the surgery, were unable to move their lower limbs. And just after the rehabilitation, and right now, and they can achieve a maximum working distance of 200 meters. And the third patient is the HSC grade patient. And this picture, the left video show the pre-operation, and she can get some contraction of the lower limb muscles, but just the HSC, not she cannot achieve HD grade. And the right video, and is about 1 year after the trial, and she tried to work with a walker at home. And this picture, and it shows the implantation site and also the devices we use. And just as I said before, the lead we use is a 32 contact electrode, and we implanted into the epidural space of the spinal canal, and which located in the lumbar enlargement. And after the implantation, we will give 6 months rehab, and mainly focused on the ambulation. And the first two patients, we already published an article on the on a science bulletin, and we show that the daily rehabs we use, and also the besides the routine, and also we show the parameter changes and the clinical outcomes changes of these patients. And we show, and for the EMG, and also for the angles, the motion angles, and also other parameter changes, and during the trial. And after the first trial, we mainly focused on the ambulation. And the next, I would like to show to use the multimodal modalities, and we try to focus on the spasticity of the spinal cord injury. For the patients, there are over 60% of the patients who suffered from spasticity of the spinal cord injury. And it just the right picture shows that for the different range of the quality of life, and they all correlated with the spasticity, and which means the spasticity really affects the quality of life of patients, and who have a spinal cord injury. Also, there are some possible models and of the spasticity, such as a loss of descending inhibitory control of the intrinsic motor neuron hyperexcitability and the maladaptive spinal network plasticity. And we use the spinal cord stimulation to try to disrupt this vicious cycle of these models and try to improve the spasticity of this patient. And to look into the research has done before, who use the epidural electric stimulation to try to treat the spasticity, and we see that there are too many hotspots that they may implanted the epidural electrostimulation, and also which lead to the unstable outcomes. And also they will choose different implantation segment, and the outcome really varies. And I just with the experience and we have done in the first trial, we was thinking that for the patient who has the spasticity spasticity of the lower limb of the trunk, whether we can use the we just focused on the lumbar enlargement and to target the selective muscles and try to help them to control the spasticity, which we have the therapy paradigm. And the paradigm consists of three parts. And the first is we use the pre-op transcutaneous spinal cord stimulation and try to check whether the patient can have the good feedback and to the spinal cord stimulation. And the second, to use the precision implantation and to make sure that our electrode is implanted to the lumbar enlargement that we want. And the third is to combine with the stimulation to give the individualized rehabilitation. These are the 5 patients, and we reported, and you see that they have the Asia A, B, and C, and they have different abilities to the WICR scale, and most of them are from the traumatic etiologies, and just one from the iatrogenic. And for the transcutaneous spinal cord stimulation, and first we give the X-ray and MRI and to show and where is the lumbar enlargement and to the level of the spinal cord, to the spinal canal. And to use this X-ray and MRI, and we try to find where to put our casnoid and anoids. And also, to have the EMG, and we should try to make sure that the transcutaneous SAS can really stimulate the spinal cord. And we use double pulse inhibition and to check this. And after that, and we will use the different parameters and to the paradigm to test whether the patient can get some relief of the spasticity with the different parameters. This is the single pulse, and the right panel is the double pulse. If the double pulse inhibition shows, and which means it stimulates the spinal cord definitely. And also this is the TSS diary, and it's an example. And we'll change the different location of the casnoids, try to make sure it can target the lumbar enlargement, and also it can stimulate the spinal cord and elicit the muscle spike. And to use after that, we will use different parameters to check whether the patient can have some relief of the spasticity of the lower limb. And we will give the 3 days in a row and to the TSAS therapy, and for the patient to check whether they will reactive to this therapy. Okay, you can see that 4 out of 5 patients, they can reactive to the transcutaneous spinal cord stimulation, but there is one patient who is Asia B. They don't have he didn't respond to this therapy. Next is precision implantation. And this part, and we should make sure that the electrode can covers all the just the lower limb segments of the spinal cord. And during the surgery, before the surgery, we will use the just the individualized reconstruction of the spinal cord. And just before surgery, we should make sure and which level we want to implant. But during the surgery, we will use the EMG to check whether it is a symmetry or asymmetry. And for the intraoperative imaging, and the electrode may see the symmetry, but the electrophysiology is asymmetry, and we will prioritize the EMG as the outcome result, and we responded to. And to make sure that for the left lower limb and the right lower limb, they may give the symmetry EMG reactions to the stimulation. And this is just one EMG during a surgery. You see that even if we put the electrode in the just focused in the center, just the central contact is in the central line of the spinal cord, according to our intraoperative imaging. But the just the EMG is asymmetry. So we should just try to move the electrode a little bit, and to adjust the electrode to get the symmetry EMG of the lower limbs. And this is very important because the post operation, and while we give the rehab, and we want the EES can assist the patient to do the rehab movement, and to get the symmetry, to get a symmetry EMG, and can give us more room to adjust the different contact and the parameters of the electrical stimulation. And this patient, and who is a cervical spinal cord injury, and you see the from the transverse section, and you see the electrode. The central electrode is not within the central line of the spinal canal, but actually during surgery, the electrophysiology is a symmetry one. And also there is another patient using this central line is quite just like centers that in the central line of the spinal canal. And the third part is individualized rehab. Individualized rehab is first is to change the contact to target the different muscles of the lower limb, and try to move the different the muscles as the same and as we need, and especially for the patient with most spasticity muscle, and we try to give more a change of the parameters and the contexts. And also we will combine the FES and with the EMG, and FES with the SAS. If the patient cannot move the just target the muscle efficiently, and we will to use these combined therapies and for the patient and try to get the better result. And during movement, and we will use our just a subjective score, and also to combine with the EMG, and to during each session, and try to identify the parameters of different joint movements, and develop personalized training plans. The patient involvement is very important. And for the left panel, you see the different EMG, just two trains of the EMG, and the left and the right. And the left EMG is a patient voluntarily and try to move her leg. And the second her wife is the patient just use the EES and try to move the joint. You see, it's quite two different EMG shows on the panel. And also that for the patient who can benefit from the transcutaneous SAS, and they can also get the benefit from the just the spinal cord stimulation implantation. And but for the all the patient, and they all can through training achieve some movement in their wakefulness duration to last at least 1 to 2 hours. Okay, to have the brief summary. Today, I just mainly focused on the movement part of the epidural electrostimulation. And for the pain, and which there are a lot of literatures and have just confirmed that for the EES to treat pain, the indication matters. And even we have some just innovative parameters, but the indication is very important to select the best patient for this therapy. And for the ambulation, we also need more exploration. And during the almost a half year, just a rehab process, and we deal with a lot of time to have the parameter searching. And so the AI-powered parameter searching will be really important, really important method in the future for this therapy, and also for the individualized rehab, and to combine it with different modalities such as robotics, and it's also very important. As for the patient selection, right now, also the other teams have reported mainly on the cases or case series to use the EES for the spinal cord injury, but not too much discussion on the patient selection. And even if we can help them to construct the ambulation with the Asia B grade patient or the Asia C grade patient, and we don't know whether there are some subgroup of the Asia A or subgroup of Asia B can or cannot benefit from this therapy. And we need more research, or even we should even maybe the TSAS is a good way to help us to select patient. And EES for the spasticity, and also the patient selection. Patient selection, I mainly say that the TSS might be a very useful tool to give a prediction that before the surgery. And also the implantation matters, because we want to cover all the lumbar enlargement and to target the different segments of the muscle. And so to precisely to cover all the spinal cord segments according to the reference of the EMG during the operation matters. And also after that is individualized rehab, and with the help of the EES for autonomic nervous system. And we also found some clues that EES can benefit for this function for the patient. And also, just as I said before, and for some patient, it is much more important for the motor function, because not only is quality of life, but also its dignity. That's all I talk today. Thanks for your attention.
Okay. Thank you very much, Dr. Yang Lu, for this very, very nice overview and very inspiring overview, if I may add. Let me start with a comment. In all indications you mentioned, pain, spasticity, ambulation, you mentioned rehabilitation. And this is something really important. It's not just about implanting 1 or 2 leads and a battery somewhere and then expecting that a miracle will happen. It's about a combination of different modalities. And in my eyes, rehabilitation is the most important one, meaning that the patient and their families should accept the fact that they have a part of the responsibility for this therapy. They must be willing to participate in all these rehabilitation exercises or programs in addition to the spinal cord stimulation. They should not expect that just by implanting such a system, suddenly they will start walking or the spasticity would be zero. Spinal cord stimulation or neuromodulation is only a part of the whole therapy. It's like a puzzle, and this is only a part of this puzzle. Some technical questions. What happens if you have a person with a cervical injury? Where would you place the tip of the lead?
You mean the tip of the lead we place, right?
Yes.
Okay, just before the surgery, and we will do the imaging and also the construction of the spinal cord to show the lumbar enlargement, which is the L2 segment to the sacral 1 segment is the part we are interested in. And for the different patient, they may have the different level of these segments, but mainly we have the thoracic 11, thoracic 12, and the lumbar 1 is the segments we are interested in. So the tip of the electrode is mainly focused on the T12 or T11.
Okay, but this is for patients who have a paralysis of the legs, of the lower limbs. What happens if you have an injury at C5, for example? Where would you place your lead in such patients? In the cervical area?
You mean the patient has the thoracic injury or
a cervical injury?
You have the cervical injury, right? Yes. Okay. Whether the patient have the thoracic injury or the cervical injury, and we implanted the electrode in the lumbar enlargement is try to focus on to improve the ambulation or the lower limb function of this patient. That's why we place the electrode in the lumbar enlargement. Yeah.
And did you notice any improvement in the upper limbs as well?
Right now, for the spinal cord injury patient, we don't initiate the program to target on the upper limb. But for some stroke patient, the patient with stroke, and we can implant the electrode in the cervical part and try to relieve the spasticity of the upper limb.
Okay. Can you comment something on the frequencies you are using during the stimulation?
Oh, okay. Actually, and for the motor function, such as for the ambulation, and if we use for the reflection of the muscle, or the muscle is we tend to use the 80 hertz around, and which is 80 to 100, and for the extension muscle, and it's more like 20 hertz or to the 40 hertz, and they can benefit for this. And for the spasticity, and it depends, and different patients are just prone to benefit from the different frequencies, and just the range can from the 2 to 5 hertz to above 1000 hertz.
Okay.
Yes.
Interesting. But and the patients are satisfied with the stimulation. They don't report any adverse effects or unpleasurable feelings or sensations or other problems. You don't have that.
Okay, just like the Mosaic on the wall, and they have said they have proposed the gate theory, and in the 20th century, and if we use the stimulate the posterior part of the spinal cord, it can elicit the paresthesia of the patient. But just you know that for the spinal cord injury patient, and some patient may have some the sensory deficit, and they may not report the paresthesia of the spinal cord stimulation, but they may report some hard to describe sensation after each rehab session. And so we should notice that it can maybe so it's hard for us to just to increase or decrease the parameter based on the patient feedback. And so we mainly to try to look at the electro EMG and try to increase or decrease the parameter. That first one is the sensation, and the second, and if you give too much stimulation for this patient, it may just exacerbate the spasticity. And it can maybe the first day it can patient may have no concern, but the second day after they wake up, they will find the spasticity is become exacerbating if we give too much stimulation. And also, and for the for others, just a complication, if we can just try to control the stimulation is in the safe range, so we don't find some complications for this patient. And just but during the rehab, and the safety is always the priority issue. And we can have the patient, they have some knee injury and during the ambulation, and but it is not caused by the stimulation. I think we think that it caused by the too much exercise and with the help of the stimulation.
Okay, thank you. And one very quick last question from me. Do you think that spinal cord stimulation is the last resort therapy, or should we start with it a little bit earlier after a spinal trauma? What do you think?
I don't think it's a last result. And I just to do the research is one thing, but for the try to change to the real world is another thing. Just we talked in the last session, and we talked about the cost, we talked about the time, we talked about the insurance, and you see the first 4 patients, and every patient, a whole bunch of people, researchers, surgeons, and therapists, and to do the at least 6 months for one patient and help them to ambulate. It's not possible for the patient to pay or for the country to pay for themselves for just one patient for such high cost. I don't think so. And of course, the even we do a lot of things that we cannot reverse the pathological condition of this patient, and also even they can work, and but they also need a worker, and they want to improve their bladder and the bowel function. And so I think just a spinal cord stimulation just to give a possibility and also one of a modality to improve this patient quality of life. And in the future, and we can emerge in other modalities, and maybe the stem cell is also promising, and the robotics and the new technologies can emerge. And let's see.
Thank you very much. There are huge ethical implications in this therapy. Professor Calabro, yes, please.
You talk about the important role of rehabilitation, tailored rehabilitation in this patient as third step of course, your stimulation. Have you ever think to combine this kind of rehabilitation with robotics? I mean, I saw the video, and they try to work, but the gait cycle is nearly 5 from the normal gait, of course. I know that it's just experimental, and it's very important because you bypass the problem of the spinal cord circuit. But do you think they can improve better, for example, if they use exoskeleton to improve gait cycle during and after the stimulation? What's your opinion about it?
Yes. And actually, the first patient, we have tried some trials with the skeleton, and also some group such as Switzerland group, Gregor Coating, and also published the article that to combine the robotics technology with the EES. And yes, we think, but right now I'm not sure whether it can just exceed the ceiling of the EES. I'm not sure, but I think robotics can help us to reduce the cost of human resource.
Yeah.
And because for every session of the patient, and if we should at least 2 therapists and also the 1 engineer, and to help them to change the parameter and to help them to work. And if we use the robotics that paired with our stimulation, we can to just save just the human resources tremendously during each session to work. Yeah.
Okay. Thank you.
Professor Srinivasan, your question, please.
Yeah, so my question is the difference between the spasticity result between EES and ITB. What has been, have you tried both to see whether in a given set, the intrathecal baclofen can give a better result when you're focusing on spasticity compared to EEC? Any take on that?
Right now, we don't have compared the results. Actually, just for the right now, I don't have more results to show you, but I think that is a very interesting question. Yeah.
Thank you.
Maybe one can combine both modalities, spinal cord stimulation and intrathecal therapy for such patients. Dr. Borba.
First of all, well, congratulate Raja and ACNS for the excellent webinar. The very high level, not only the presentation, but also the chairs, the people that really know that they are talking about. I want to ask you a consultation for you here. We are seeing, it's not common, but you can see a patient that you operate the intramedullary tumor, and the post-op, they have sometimes spasticity and sometimes spasmus. See? You try baclofen, I don't know what's the oral intake, or there is some work comparing baclofen pump and spinal cord stimulation for spasticity in several levels. If there is something that you can compare these two therapy, I think the cost to be completely different. And maybe the spinal cord stimulation, as Giorgio said, it'd be the last one option. But maybe you're not so last, maybe early, maybe we are losing time, or you are not using the correct time. What do you think about compare the medication in spinal cord is stimulation?
Okay, just actually, just our two professors talking about baclofen pump. Actually, that right now in mainland China, the baclofen pump is not available right now. Actually, and the pump is available, but the drug is not available. So if we implanted the patient with baclofen pump and a patient, they have to just to get the drug is very difficult for them. They cannot get the drug in the hospital. And also for the spinal cord stimulation, I think is one thing is different from baclofen pump is that and right now with the rehabilitation to combine with the EES, they might get the improvement of the function and for the motor and for the autonomic function, and which is also another consideration of the patient who want to improve the spasticity. That's the answer I want to say.
Dr. Srinivasan, what do you think?
Yeah, so in India, interestingly, we have the baclofen available. So I've been implanting a lot of intrathecal baclofen pumps because again, the cost is much lesser compared to an SCS. So what I see is just with baclofen, even the pain comes down tremendously. So that's one thing. And I've got some, we do rehab for 6 months, 1 year sometimes after the implantation of pump. I tell my patients minimum 6 months, otherwise you don't put the pump. And a couple of them, Asia B and partial Asia C, have done reasonably well. One person who was Asia C actually has gone back to driving his car. He's able to sit down on the ground and get up. So and over time, the spasticity came down. I've been reducing downgrading his dose of medications required after 5-6 years. But it's very interesting. So I've got some interesting results in spinal cord injury with intrathecal baclofen pump. I can share it sometime.
Thank you.
Thank you.
Just two small comments. First on, you can combine spinal cord stimulation and oral baclofen if you don't have the intrathecal therapy, if you don't have the pump or the drug to fill the pump, it could work. This is what we see also in patients with chronic pain who have a spinal cord stimulation system, and we add baclofen tablets, and they respond pretty well. And the second is that all publications that we see on PubMed about spinal cord stimulation and spasticity were done with tonic stimulation, with paresthesias. And the big question now is what would happen if we organize somehow a new study with different waveforms, with different types of stimulation, burst DR or high frequency or whatever, or combination of those waveforms, and to see if the results would be better than the results we got when we applied tonic stimulation many years ago. This is an open question.
Yeah, very interesting.
Right. Thank you. Thank you very much. It has been a very interesting session, and thanks to Prof. Barba and all other dignitaries who joined in. So I will like to hand over the podium to Prof. Mattis for his concluding remarks.
Well, for me, after almost 90 minutes of a webinar, my takeaway message is that rehabilitation plays a huge role in the treatment of such patients. Once again, it's not only about implanting a neuromodulation device, it's a teamwork, it's really a teamwork. And secondly, when we do offer our patients this spinal cord stimulation therapy, we do see a variability in the response. And then comes the big question, how can we ethically balance the hope of the patients and their families with realism when we select the candidates for this therapy, especially when patients and their families are coming to us and they are looking at this therapy, they are viewing this therapy, they are considering this therapy as the last beacon of recovery. There we should be really careful.
Thank you. Thank you very much. So I'll close.
Thank you.
Thanks, Prof. So we'll close this officially now on behalf of the Education Committee of the ACNS and the President, Prof. Yoko Kato. I would like to thank both the speakers of today, Prof. Rocco Scalabro and Dr. Liu Yang, as well as the chairs, Professor Sharan Srinivasan and Dr. Georgios Martis, for the time and support for the ACNS webinars. Very special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel. And as I mentioned earlier, we have around 690 people who have logged in all across the world through different channels. Thanks to my special host Libun Singh and also Professor Luis Baba for joining us today. Until we all meet online tomorrow, it is bye-bye from all of us. Thank you very much for joining.